All right, everybody, here we go. We're talking about Chapter 10, Fluency Disorders. We'll be talking about what is a fluency disorder, how are fluency disorders classified, what are the defining characteristics of fluency disorders, how are they identified, and how are they treated. All right, we're talking about a lot of terms here. Fluency, which we'll talk about more in depth in a second, is a descriptive term used to characterize the flow of speech during communication. Disfluency is a speech behavior that disrupts the fluent forward flow of speech, the fluent forward flow of speech even, such as pauses, interjections, and revisions. We'll talk about core and secondary features of stuttering. And we'll talk about a lot of terminology, including prevalence and incidence of stuttering and other fluency disorders. All right, so fluency is a descriptive term used to characterize the flow of speech during communication. Speech is fluent when it has typical rate and rhythm and appears smooth, effortless, and automatic. So speech is fluent when it's just forward flowing, smooth, easy. One of the best examples is think about a nice stream and just the nice, easy flow of water down a stream. And, when people are really fluent, they're just, the words are just coming out. They all make sense and it's easy and smooth. And it's only when that smoothness and easiness is disrupted that you start to notice there's a problem. All right, fluency disorders. Stuttering and cluttering are the most common fluency disorders, and the ones we'll talk about, mostly stuttering because it's the most common fluency disorder. Stuttering is speech with an unusually high rate of stoppages that disrupt the flow of communication and which are unusual for the speaker's age, culture, and linguistic background. It impacts fluency and timing patterns. These stoppages or these repetitions or pauses or prolongations. It often has a negative impact on social communication, academic performance, and or occupational achievement. So for most people who stutter, it's going to impact them in at least one of those, if not all of those areas. All right. It's interesting. One thing I really teach as a professor and a speech language pathologist and someone who specializes in stuttering and somebody who stutters, I really teach my students, and when I go out and give presentations, I teach other practicing speech language pathologists to use the term stuttering. I think very often people are afraid to use that term. They use disfluency or another euphemism. It's really important actually to use the term stuttering. In the 90s, people got very into using person-first wording, so that someone isn't a stutterer, they're a person who stutters. Someone isn't autistic, they're a person who has autism. Because having that person in front of that, focused on this is a person who happens to have this thing. However, there's now a really big movement, certainly with people who have autism and people who stutter, to actually use the term autistic and to use the term stutterer. And one of the big reasons for that is that if there's nothing wrong with the word stuttering, then there would be nothing wrong with calling a person a stutterer. So my wife is a big runner. She does marathons, she does ultra marathons. She's run like 50-mile races. She's crazy, right? But she's a runner, right? So I imagine someone calling her a runner and her going, no, I'm not a runner, I'm a person who runs. I'm more than just a runner. Well, no, she wouldn't do that. And why wouldn't she do that? Because running isn't a bad thing. Well, what a lot of people, including me, are trying to say is that, well, stuttering isn't a bad thing either. So I don't have to be a person who stutters. In fact, you telling me I need to put person in front of that makes me think you think stuttering is a bad thing. I don't think it's a bad thing. So I'll often use the word stutterer interchangeably with person who stutters. However, if I'm talking to somebody new, someone who stutters, it may be, offensive to that person, which is fine. So I'll usually err on the side of caution, use person who stutters. But to me and to many others, there's nothing wrong with the term stutterer. And I hope we keep moving more in that direction. I think it's a good thing. All right, prevalence and incidence. Prevalence is how many people stutter right now. Overall, it's a rate of about 1 in 100 people. Most of those people are going to be kids. So about 5% of kids kindergarten age and younger go through at least a period of stuttering. But a lot of people recover from stuttering and stop stuttering at some point. So the overall prevalence is about 1 in 100 people. The incidence rate, how many people will say, yeah, I stuttered when I was little, or, I got into a car accident and I stuttered for 2 months, or I had a stroke and I stuttered for 3 months. About 5% of people at some time in their life will stutter. So there we go. 5% have stuttered at some time in their lives. Only 1% of those are currently stuttering. About 1.5% of children under the age of 10, like I said, somewhere between ages 3 and 5, maybe even 5% of those kids will go through a period of 2 or 3 months at least where they stutter. Whereas adults, we're talking about, 1/2 to 0.7, that should be 0.7% of adolescents and adults stutter. So I think that's probably about right. Probably about 1 in every 200 people stutter. Adults are really good at hiding their stuttering. Teenagers are really good at hiding their stuttering. So you may well know people who stutter, but not realize that you know people who stutter. Males are much more likely to stutter than females. For kids, it's about a 3-to-1 ratio, but females are also more likely to recover. So as adults, that number gets up to about a 5-to-1. I've even seen a 7-to-1 ratio for males to females. Recovery from stuttering. Recovery in conjunction with treatment is called assisted recovery. Unassisted and spontaneous recovery refer to recovery that occurs without treatment. Spontaneous recovery occurs in about 75% of cases, usually in the first 3 years of onset. So, kids are most likely to start stuttering between the ages of 2 and 4, and about 75% of the kids who start truly stuttering are going to recover within the first 3 years of onset without any kind of therapy. We've got 2 types of therapy, and we'll talk about that in a little bit, that we think we can get that recovery rate up to about 90%. So recovery in conjunction with treatment, assisted recovery, we think for those young kids, we can get that assisted recovery rate up to about 90% from the 75% of unassisted or spontaneous recovery rate. Once you've been stuttering for 3 years, you're probably always going to stutter to some extent. Only about 5% of people are going to recover after they've been stuttering for 3 or 4 years. All right. The defining characteristic. Really, it's that disruption of speech, which for the intermediate and advanced stutterer, and even for little kids too, it's going to be sound, syllable, and word repetitions, sound prolongations, and blocks. And these are also referred to as the core behaviors, and they're also referred to as stuttering-like disfluencies, which we'll talk about in a second. So it's the sound and syllable repetitions, especially sound prolongations and blocks, are the core behaviors. But then we also have secondary behaviors. And we also have attitudes and feelings, and we'll talk about those. So core behaviors, so it's the speech disfluencies are really the original and primary source of communicative difficulty which people experience. Now, the disfluencies themselves are really, come out as a symptom of, some kind of neural glitch, right? That people who stutter have, something in the speech regions of our brains. We have a glitch that doesn't allow us, or doesn't make it as easy to speak fluently as the average person. And the big symptoms that let us know that, wow, I'm not a typical speaker, are going to be those disfluencies. And they're often called, and probably the best term is stuttering like disfluencies. So we've got part word repetitions like this. Also a little bit single syllable word repetition. So mom, can I. We also have sound prolongations where we're actually prolonging a sound within the word. And then blocks are where you're basically, the person who stutters is taking their larynx and taking their vocal folds, slamming them together like you would, if you're picking up a heavy object, if you're moving your couch and you cut off your airflow to build up that good old air pressure. People who stutter, it can often trigger a block where they stop breathing mid-speech. And those are called stuttering-like disfluencies because they're not like the typical everyday disfluencies that people have, like, interjections, the ums, the uhs, the likes, the wells. It's just normal hesitations. And also, people who don't stutter are more likely to have longer repetitions. So that for people who don't stutter, they're more likely to have multiple word, multiple syllable repetitions. Whereas the shorter the segment of speech that's repeated, the more stutter-like that disfluency is. So this is much more like stuttering than this is, which I've got multiple words, I've got multiple syllables. Typical speakers do that all the time. We barely even hear it, don't think about it. It's not tense, it's not stuttering. I hope that made sense. Secondary features, feelings and attitudes. So these moments of stuttering are going to be different. And especially if a young child has blocks where they're holding their breath while they're talking and aren't trying to, it can be really scary. And then when you realize that you're not talking like other people, or when parents or peers or teachers are like, hey, why do you talk like that? What's wrong with you? Don't you know what you're saying? That can cause anxiety, embarrassment. It makes people feel stupid. Some people feel angry. People feel isolated. They can feel guilt, shame, hopelessness. So, and as the person gets older, we're going to get more and more of that. Usually for little kids, it might be just a momentary feeling of fear or a momentary feeling of, I don't know what's going on. But as people get older, and kids start getting into 3rd, 4th, 5th grade, more and more negative feelings and attitudes are going to come up. And that's part of the reason why we have secondary features like escape and avoidance behaviors. And escape behaviors include things like head nods, eye blinks, interjections, right? So if I'm talking like that and I'm a little kid, if I'm talking like that, whoa, I just threw in that and I was stuck, and it allowed me to then go forward. All right, so I threw in an interjection. and it works. So escape behaviors, I've already started to stutter, and I do something to get me out of that moment of stuttering. And it can also be something physical, like a head nod, an eye blink, right? If I have a lot of pressure and tension, and I nod my head, I blink my eyes, I tap my foot, I do something different, it's going to move that pressure away. Boom, word pops out, right? And as a 3-year-old, 4-year-old, I'm going to learn that, hey, this is how I can get my words out. Right. But the problem is, well, but typical speakers don't do that. And now you've got stuttering plus interjections, or stuttering plus head nods, or stuttering plus eye blinks, and it just gets more and more complicated. We also have avoidance behaviors. So this is sort of one step up from escape behaviors. With escape behaviors, you start to stutter and you do something to escape out of the moment of stuttering. With avoidance behaviors, I know through history or through that tense feeling that I'm going to stutter, and I do something to avoid it. So I never actually stutter. So it might be a word and I change words, or I don't like the first sound, so again I change the word, or circumlocution. Maybe I talk around a word for a while, I add in other words, I talk about something else and then work my way back to it. And it can also end up in whole situation avoidances. So, right, I don't want to stutter, so I don't go to the middle school dance, or I don't try out for the baseball team because I don't know the head coach, or I don't apply for a job, or I don't major in what I want to major in college, or right. So it can have these huge situation avoidances, right? I don't ask out a girl on a date because I don't want to stutter. Okay, well, I never stuttered. No one saw me stutter, but I didn't do things I wanted to do. So it can really have life-altering impact when people start avoiding. And so one of the big keys really is to get people not to avoid as much as possible. Don't avoid words, don't avoid situations, just go ahead and stutter. All right, so preschoolers, right, they're going to have those repetitions of words and sounds, sound prolongations, the blocks, usually just escape behaviors at this point, but I've certainly known even 2-year-olds to have some avoidance behaviors, but usually they're just going to have escape behaviors, those head nods, eye blinks, and interjections, just to get out of that moment of stuttering, right? So if you're 3 and you're stuck, right, you might do something physical, boom, helps you get out of a moment of stuttering. Doesn't seem like that big a deal, but it can become a big deal. As kids get older, there's repetitions, prolongations, and blocks, and the blocks start becoming more prevalent. And the thing about the blocks is, I think a lot of times kids think that blocks are actually a good thing, that, oh, no one, if I'm silently blocking, right? So if I'm talking like that, right? Well, maybe the child doesn't like the way that sounds, or the parent doesn't like the way that sounds, and so then they change to, if I'm talking like that, oh wow, I didn't have that repetition, I didn't have that what people would perceive as a moment of stuttering, and although that was a more severe moment of stuttering as a block rather than a repetition, so that this is actually better than this, right? Even though you'd say, oh, you didn't have that repetition. That's great, but it's not great. It's actually, the person's holding their breath, they're silent, they're not moving forward. We want to try to help kids get back to repetitions and not be blocking and trying not to stutter. And so it's a sort of a form of avoidance, and these become more evident and habitual. And this is sort of the intermediate level of stuttering, where now we've moved past sort of a beginning level that child might grow out of it, or maybe we can do some therapy to help the chances of recovery, now we're at a place where this child's probably always going to stutter, and how can we help them to manage their stuttering, cope with their stuttering, be a really awesome talker, awesome kid, awesome communicator, and just happen to stutter sometimes too. As people get older, it's going to be similar to school-age children, but adults are really good at hiding their stuttering, really good at avoiding changing words, knowing exactly when they're going to stutter and how they're going to stutter, just from having years of experience with it. And so, they do these things not to stutter. But then when they do stutter, sometimes it turns into a huge moment because there's sort of this buildup of, oh my gosh, I'm going to stutter and I don't know how to get out of it. I don't know how to get out of it. I can't word change. Maybe they have to say this word, and they've been talking for 5 minutes completely fluently, and now they're going to get into a moment of stuttering, and no one's seen them stutter, and so they're going to have this huge moment of stuttering that's now tense. And whereas if they weren't worried about it, maybe they would have had a bunch of small moments, but not a big deal. But now they've built that up, and it turns into a big moment of stuttering. Again, they're really sophisticated at avoiding and escaping moments of stuttering. And this is where we would really call an advanced stuttering. It almost sounds like it's an advanced degree or something, where they get a certificate for being, an awesome stutterer. And I guess in some cases, you can feel like that, but it also can be really negative, because again, if you're working at a job that you hate and that you would be doing something completely different if you didn't stutter, that's terrible. That's a huge negative impact on someone's life. The actual moments of stuttering don't really matter. It's, if someone's avoiding something so that they won't stutter, that's much more of a problem than the stuttering itself, usually. Now, we've really been talking about stuttering that starts, between ages 2 and 5, and then, either the kids recover or they don't recover, and the stuttering sort of grows and changes over time. But we also have acquired fluency disorders, and these can be the result of illness, trauma, or accident affecting the brain, or even psychological trauma, but that's rare. So neurogenic stuttering, someone has a head injury, or you have a TBI, a stroke, a tumor, and that actually leads to stuttering, kind of like we learned about when we were talking about aphasia a little bit. And you can also have some psychogenic stuttering, which is going to be, some kind of big psychological trauma where someone starts to stutter. Usually once someone works through that trauma, the stuttering goes away, and that's really, really rare. Almost nobody stutters because of something psychological. It's really a neurological disorder for the most part. All right, just quickly, the other fluency disorder is cluttering, and this is rapid or unusual rate of speech that results in disfluencies, frequent and unusual pauses, and a blending of sounds and words. I will put up a little video about cluttering for you so you can hear it. Disfluencies consist of more interjections, phrase repetitions, incomplete word production. So this is actually much more like the disfluencies you hear might be more like that of a typical speaker, although often people who clutter have rapid or unusual rates, so talking really, really quickly, might have unusual pausing, so pausing in strange places in words, and then blending words together. So if someone says like my refrigerator, it might come out my rerator, my rerator. And the person's like, what? I don't understand what you're saying. And so that kind of plays into, well, people who clutter also are going to be much more likely, even more likely than people who stutter, to have articulation errors, which plays in. And then, people who stutter often have a hyper awareness of their stuttering. Like they are upset about their stuttering. They try to hide it. They don't like how it sounds. They don't like how it feels. People who clutter are the complete opposite. They have a complete lack of awareness, usually, that there's anything wrong. When someone who clutters comes to therapy, they say, I'm here because my mom wants me to be in therapy. I'm here because my teacher said can't understand me. I'm here because my boss said he can't understand me. My coworkers wanted me to come in and get speech therapy. I don't really know why. So there's really a lack of awareness that there's anything wrong. And so, we got fast rate, we've got blending words and sounds together, articulation errors, and really a lack of awareness that anything's going on. And really it can present itself like a mild language disorder, a mild speech sound disorder, someone with attention deficit disorder, and a very fast rate of speech. And if you mix that all together, you might get cluttering. Okay. Causes and risk factors, just like everything else we've been talking about. We don't really know what causes stuttering, although I think we kind of do know what causes stuttering. We've got predisposing factors and precipitating factors. Predisposing factors are also called constitutional factors, and these are the things that make a child more susceptible than other children to develop a fluency disorder. The biggie is just going to be genetic. So about 70% of the time, this is a straight genetic neurological disorder where it's just handed down in families. Males are much more likely to stutter than females are. In that other 30%, we've got differences in brain structure and neural physiology. Well, this is true for everybody, but I think just, we get some random differences in brain structure, and or kids who have had complications at birth are much more likely to stutter than kids who have not had complications. So kids who have, instruments have had to be used, kids who have stopped breathing for a period of time, either during or right after birth. These are the kids that are going to be the kids who don't have the genetic history. These are the kids that are going to be more likely to stutter. These are also kids who are going to be more likely to have attention deficit disorder, and then also motor speech coordination, just sort of overall motor speech coordination. And stuttering really is a motor speech disorder. It's not called that, but that's kind of what it is. All right. Then we've got precipitating factors, which are factors that can sort of increase or decrease the amount of stuttering that we'll see that the person will present with. One can be age. It can be really hard as a teenager. Also, right, the stuttering is going to start at age 2 to 4, right? Being age 3 doesn't cause stuttering, but age 3 is when that stuttering is going to emerge. Also, developmental stressors, right? Kids go through big language explosions around age 2 and 4, new words, long sentences, adult-like speech. All these things are going to be, a factor in why the stuttering starts when it does. Also, kids start to be really aware that, wow, I'm not talking right. I'm not talking like other kids. I don't like this. I want to try to do something different. And that's when we get a problem. All right. So for years and years, there was a diagnosogenic theory of stuttering, which was the idea that stuttering was when parents and or caregivers would diagnose stuttering. That's where diagnosogenic name comes from. Parents or caregivers would diagnose the child as stuttering, and it would just be, a child would just have normal disfluencies, and parents or teachers would hear that and say, oh, don't do that, don't talk like that, stop and start over, take a breath. And the idea was that that's actually what caused the stuttering, that kids just have normal disfluencies, and because of, parents, caregivers, that they actually cause the stuttering. And one thing that was done at the University of Iowa in the 1930s is, and it's been dubbed the monster study for various reasons, but is they tried to take orphans and make them stutter. And they never actually stuttered. They just reported later that they really didn't like talking. So they would tell them, "Oh, you're not talking well. Can you stop and start over? Can you say that again? Can you say that better?" So not the kindest thing to do to people. Didn't ever cause anybody to stutter, but certainly didn't make them thrilled about the way they talked and the way they talked in the future. So now we know now that, and what ended up happening is, because that study didn't end up supporting the view of the diagnostic theory, the study was kind of hidden away and nobody knew about it until the 1990s. So there was a big article about it, and people sued the University of Iowa because they had all these years of not talking. So it became this big deal, but it wasn't really, the study wasn't hidden because they had mistreated orphans. The study was hidden because it didn't support their theory. And unfortunately, these are the things that science did in the 1920s, 30s, and 40s. And it really wasn't until the Nazis were discovered doing, atrocious things to people that we totally revamped the way we did science. But before that time, I mean, we were doing horrible things to people, and this is just, one thing that was done. All right, assessment process. We've got referral, we've got assessment, diagnosis, prognosis. SLPs are specially trained for assessing, diagnosing, and treating stuttering and cluttering. We know we're going to look at warning signs for developmental fluency disorders and acquired fluency disorders. We're going to ask 4 main questions. Is the individual currently stuttering or at risk for stuttering? Do they exhibit any other communicative risk factors or disabilities? Kids who stutter are going to be more likely to have other speech, language, and learning disorders. And then we also need to know, do we need to have therapy? Should we do some wait and see? And then what therapy approach would be most beneficial? I've got a case history and interview, a speech observation, question and survey, direct testing. A fluency disorder is more likely to be diagnosed when at least one of the following are observed. Either 10 or more total disfluencies in 100 words. We don't really use that as much as was done in the past. I'm actually personally not concerned about total numbers of disfluencies. You can have kids who have tons of disfluencies. I have a lot of kids. I've said that before. I have a 3-year-old right now who's got awesome language skills, great speech skills, and she has a ton of normal disfluencies. So, Dad, can I have, Dad, what are we going to have for breakfast? Right? So just like this long thing of disfluencies, they're not rushed. They're not hurried. They're not, like sound repetitions. They're repetitions of whole words or multi-word repetitions. Totally not worried about it, right? So it's those SLDs. It's those stuttering-like disfluencies. If I get, maybe 1, 2, or certainly 3% SLDs, I'm going to be much more concerned about stuttering than I am if a kid has a ton of disfluencies, but they're all normal and typical and just totally fine. And then we're also going to look for any escape behaviors or avoidance behaviors. If someone's doing that, we're probably going to get them into therapy pretty immediately. Prognosis describes the likelihood that the symptoms of a disorder will be resolved with time or treatment. So big factors: age of stuttering onset. The earlier a child starts to stutter, the greater the chances that he or she's going to recover. So if we have a 2-year-old who started to stutter, he has, right, his speech is going to change a lot between age 2 and 4, and his stuttering will change a lot between 2 and 4. So he's got a great chance of recovery. Kids that start to stutter after age 4 are going to be the least likely to recover. At age 4, your speech starts being really adult-like. It's not going to change a whole lot. It'll get a little more complicated, but your speech is kind of the way your speech is. So if you start stuttering when you're over age 4, there's a good chance you're always going to stutter. Length of time since onset. Someone that just started to stutter, you know, if we're talking about a 2 to 4-year-old, they have a 75% chance of recovery. Someone who's been stuttering for 3 years, you've got about a 5 or 10% chance of recovery at best, right? So how long it's been since onset is big. Types and numbers of core and secondary features, right? So if we've got secondary behaviors, if we've got escape and avoidance behaviors, right, that's going to be a big issue. Presence of individual risk factors, all right? Remember, males are going to be more likely to stutter than females. Also, right, we've got genetic history. If the child has a father who stutters, the chances that that child recovers is going to be a lot lower than if no one in the family stutters, or if someone in the family used to stutter but then also recovered. Well, the chances are good then that child's going to recover as well. All right, how are they treated? Treatment techniques for children, we'll talk about those. We'll talk about treatment for adolescents and adults. And then also client and caregiver perspectives. All right. Should preschool children with borderline stuttering, receive treatment or take a wait and see approach? And, you know, this really depends on those risk factors we just talked about. If we have a little girl who's, you know, 3, she just started to stutter, there's no family history of stuttering, she's got great speech and language skills, I'm going to absolutely take a wait and see approach. If we have a little boy who's 4, whose father stutters, we're going to get that kid into therapy as soon as possible, right? So it really depends on the child and what those risk factors are. All right. For preschoolers, we're going to start out with indirect treatment and really environmental changes. So I'm going to have parents talk really slowly. I'm going to have parents not ask many questions. I'm going to just have parents be really good listeners. The way parents interact with children does not cause stuttering. This is a neurological disorder. However, the way parents interact with children can increase the chances that that child will recover from stuttering. So if we have a child who, because of neurological differences, stutters, but he's given a lot of time to talk, mom and dad talk very slowly, things are very relaxed, he's not asked tons of questions, he can comment or not comment, there's no pressure on him, that child's going to be more likely to recover than kids that are in a very fast-paced household. Mom and dad are talking quickly, mom and dad are using huge words, mom and dad are using long sentences, and things are hectic, and right, that kid's going to be less likely to recover. All right. And then we also have operant training models, so kind of a behavioral approach. Here we're going to get parents to identify disfluencies and provide positive input for fluent speech. So right, we're going to start with those environmental models, see if parents doing that for maybe 3 to 6 months helps. If it's not helping, we're going to go to an operant training model, have parents, you know, support fluent speech. Oh, that was fluent. You're talking so nicely. That was really smooth. Super job. And then every once in a while, we're going to have them do a self-correction. So so we want lots of praising for fluency. Every once in a while, we're going to say, oh, that was really bumpy, or oh, I heard a stutter. Let's change that. So if the child's like, mom, can I have, oh, that was bumpy, say mom. Mom, can I have French toast? Yes, here you go. Okay, boom, great job. So it's going to be really positive, but it's going to be, oh, that was, try to say that again. And so that can be, again, we think that each of these models on their own can get that chance of recovery for young children, children under the age of 6, up to about 90%. All right. Now, we also have sort of current approaches to stuttering treatment. For this is going to be for kids age 6 and up. We've got stuttering modification, which is going to be helping kids and adults to really modify moments of stuttering and manage their stuttering. So they can take a hard moment of stuttering and they can ease out of it. So something like that, or doing something like that, where I'm going to stutter, I'm going to modify the way that I stutter, ease out of it, but maybe throw in some stutters on purpose, just make it really easy, relaxed. Okay. The other sort of model is a fluency shaping model. This is where people will be taught really relaxed breathing, or pausing and phrasing, or really easy onset of voicing. Right now I'm really working on getting my vocal folds to start really quietly and almost a whisper, and start slowly. So I start slowly and quietly, and I build up to a normal rate, normal speed, and normal loudness. So those are some fluency shaping techniques. So there, we're not with fluency shaping. You don't deal with the stuttering. You help to teach people to be fluent, or a combination of both. So most clinicians will teach, all right, here's what you do when you have a stutter. You can modify it, and here are some things you can do to stutter less often with fluency shaping. So we're going to use this for adolescents. Modification teaches the adolescent about stuttering to demystify the disorder. So part of stuttering modification also, I want kids and adults to know what stuttering is, to know how they stutter, to know why they stutter, to just completely understand it, to be able to talk about it, to be able to tell people about it, to be able to do it on purpose. So that they demystify it. It's not scary, it's not weird, it's just something they do. It's just how they talk, not a big deal. One of the programs that does this is the Successful Stuttering Management Program in Washington State. Phase 1 is really confrontation of stuttering. So again, learning about stuttering, stuttering on purpose, talking about stuttering, really opening up about stuttering. Then you learn how to modify your stuttering, or modify, your stuttering, and then sort of go through a maintenance phase where you try to keep going, keep talking about stuttering with people, keep doing voluntary stuttering, keep being able to change the way that you stutter. And this is going to be really true for adults as well. Give them knowledge, reduce a lot of the negative feelings, and when possible, build up fluency for the people. All right. Fluency disorders can affect speech and self-esteem and emotional well-being. With young kids, we're going to really train the parents, and really I want to educate parents. If parents are really freaked out about stuttering, it's going to teach their kids to be freaked out about stuttering, and we don't want that. We want parents to be as relaxed as possible, help the kids be as relaxed as possible. They'll do a much better job being able to work on their stuttering and just talk about their stuttering if they're relaxed about it, than if they're really tense about it. And again, we want to, help people not avoid their stuttering. I want my clients to stutter. I want them to stutter on purpose. I want them to have real stuttering. I don't want them avoiding. You never improve. That's a bad word, but you never learn how to manage your stuttering if you don't stutter. So I want them to stutter. I want them to feel okay stuttering. And and know that they can be great and do what they want to do and still have some stuttering. That's okay. And that is the end of our slideshow. Thanks, everybody.